Bismillahirrahmanirrahim. Doctors, today we are going to start psychiatry for AMC MCQ exam. So this is the first lecture on psychiatry conducted by AMC Prep Academy. So first of all, you need to know which resources we are going to follow for psychiatry. So resources to follow for psychiatry, we will use John Murtagh 8th edition, chapter 10, 12, 68, 69, and 70. Kaplan step to CK, we will take help from as well Kaplan step to CK and use websites for guideline RACGP and Medscape. And for QBank, we will solve, you people solve QBank from U-word psychiatry. After completing the theory, you will you people need to solve U-word psychiatry. Psychiatry also in emetics as well, but uh, this psychiatry QBank, which is in emetics, is not enough for exam. So you will solve U-word psychiatry after basic theory. And then AMC Prep Academy notes almost all the important higher things we are compiled in the notes. So the notes is enough, but the recommended chapter you will go through in one time and only reads the important things which we discuss here in our classes. And then we have psychiatry course classes by our platform. So doctors, the first topic is depression. Guys, don't be depressed for AMC exam. Inshallah, you will do this. And our psychiatry first topic is depression. Okay, so depression. For depression, we have criteria to make diagnose, and this is the mood disorder that present at least 2 week course of symptom that is seen from patient previous level of functioning and must be depressed in hedonia in ability to enjoy himself. So, what are the symptoms which present for, in patient to make a diagnosis? In depression, we have basically 9 symptoms, and in 9 symptoms, out of 9 symptoms, 5 symptoms must be present to make a diagnosis. And the symptom for depression, the first symptom which should be present must is depressed mood. Depressed mood or irritability. Then anhedonia, decrease interest. Interest. Interest in usual activities. Anhedonia. These two symptoms must present to make diagnosis. And then feeling of worthless, guilt, sleep disturbance, insomnia as well, as the patient with suicidal ideation. This is one of the most important question in history to rule out this suicidal ideation. This is the recall as well. Then patient with psychomotor retardation or agitation. As well as along with appetite, decrease appetite, weight changes. Weight changes. And next one, decrease concentration. Concentration of a patient decrease during any work. And the last one is decrease energy. There is a no energy, fatigue like all the time. So this is a 9 symptom, and out of 9 symptom must present 4 to 5 symptoms to make diagnose for depression. And these symptom will goes for 2 weeks. Then we will make it is diagnosed as depression. And in question you will see the 4 to 5 symptom, and you will make, and it persists for to at least 2 weeks. You will make diagnosed as depression. For example, this is the case of 70-year-old woman was recently admitted. Her son informed the doctor that she had doing very poor over the past few months, and the patient reports a 30-pound weight loss, decreased concentration, feeling of helpless, hopeless, decreased energy, depressed mood, and decreased sleep. So see here, uh, how many symptoms are present? One, decreased concentration. Two, feeling of helpless, hopeless. Three, decreased energy. Four, depressed mood. Five, decreased sleep. Six. So the criteria for depression to make diagnosis for depression is fulfilled. So a definition greater than 2 weeks, a symptom persists, and risk factor will be the more frequently seen in the woman due to several factors such as hormonal, different stress, and the age onset. The depression rate increases after the age of 40 as well. And then many studies have reported the abnormality in the serotonin, norepinephrine, dopamine level in our body, and as well as including the family histories, positive stressor behaviorism, which lead to the depression. And the symptoms we already discussed. So the most important things to rule out in the history, symptom to rule out in the history is suicidal ideation. Suicidal ideation is most important things to rule out in the history. And if the patient have plan for suicide, so you have to admit either voluntary or involuntary. If patient is not agree, then you have to admit involuntary. Overall, in medical ethics, so if patient is didn't agree, we will let him to go. It's wish of patient. But in psychiatry patient, if patient is not agree, then we have to go with involuntary admission, because this is harmful for patient as well and other. And
This
if
is harmful
who's my phone?
patient as well as Aiza.
Doctors, please.
Nearly every day for 2 weeks. यार हमें तो depression है. Recurrent thoughts about death.
Dr.
Depressed
Aisha,
mood most of the day. Anhedonia during most of the day. Significant weight loss.
Dr. Aisha, please. Mic mute. Okay, so move to next, and the important things to make diagnose for depression is anhedonia. Important for diagnose anhedonia, and important to rule out is a suicidal ideation. So doctor, remember this. In history, you will ask about ideation, and for to make diagnose anhedonia must be present or depressed mood. Anyone is present, this is should be present in 5 symptom at least out of 9 symptoms. So this is the DSM-5 criteria for a major distraction. At least 5 of the following symptom nearby every day after 2 weeks should be present. And these symptoms we already discussed. Depressed mood, irritability, loss of interest, player activities in playful activities, change weight, sleep, psychomotor, energy, worthless or guilt, impaired concentration, susceptibility. So this is extremely important to roll out during the history. If the patient have planned to for suicide intent plan, we will ask in history. And this is the mnemonic misgaps you can read with the help of mnemonic. Mood changes, sleep thought changes, interest, and diagnosis depression. In DSM-5 criteria, we have multiple things. DSM-5 criteria. This is the latest DSM-5 classification. So, including we have persistent depressive disorder, in which there is the symptom of depression persists for 2 years, as well as premenstrual dysmorphic disorder and bipolar disorder 1 and 2. And also we have excluding criteria including previous mania, hypomania episode, and major depression divided, classified into mild, moderate, and severe. So mild, moderate, severe have on. In severe, the patient have intent plan for death. In moderate, their social life is disturbed. For example, the patient is not going to work, not enjoying an activity, but eat on time like this. But in severe, all the activities of patient as usual life is withdraw and have planned to suicide. In mild, there is a little bit changes in the mood as well. So for this, you have to go through a chapter, I think 69 of John Murtag, as I mentioned earlier. And the DSM-5 criteria, mood disorder, major depressive illness, hypomanic, depressed mood, MDD, these are things are including in the DSM-5 criteria. Major depression and disorder, persistent depressive disorder, disrupt mood, premenstrual dysmorphic disorder. These are all including in the DSM-5 criteria. Then bipolar disorder, bipolar 1 and 2, cyclothymia disorder. These are including in the DSM-5 criteria. Then how to diagnose, diagnostic approach. The diagnosis of depression will be made on the basis of history, symptom, and then we can, if need, we will go for mini mental state examination. The two key criteria for important disorder, MDD, a DSM-5 criteria, a rapid and persistent for at least 2 weeks. This symptom persists for greater than 2 weeks. We will make diagnosis as depression, major depressive disorder, MDD, also known as MDD, and including sleep issues, fatigue, lack of energy, poor concentration, feeling of worthlessness. These are all the features of depression, so as we discussed earlier. Then on a physical examination, we will see usually within the normal limits in physical examination, but the psychomotor retardation, psychiatric condition is affected, stupor, slowing of movement, slow speech, and as well as along with cognitive impairment, decreased concentration and forgetfulness. If the feature present, a patient present with psychotic feature, it means there is a worse prognosis. Worse prognosis in case of psychotic feature if present with MDD. In case of MDD, major depressive disorder along with psychotic feature. Psychotic feature mean there is a psychotic mean there is hallucination and delusion. Hallucination plus delusion are present is known as psychosis. Patient are in psychosis. Psychotic feature. Oh, sorry. Hallucination and delusion. Hallucination mean there is like the patient listen or see the things which is actually not present over there. And in case of delusion, there is a fast and firm belief of patient, fast and firm belief, no reality, but their fast and firm belief. In case of delusion and hallucination, maybe it will be either auditory hallucination or visual hallucination. Visual mean might be the patient will see the snake or cloning in his wall, in his room wall, and might be the patient will claim that I am listening the voice of angels like this, and I am talking to the uh, Trump like this. There is no any reality, but the patient claim like that. And in case of Druyan, there is a fast and firm belief. Their belief have actually no reality. So if these are present with major depressive disorder, it means there is a worse prognosis, and it is very dangerous if both conditions present at a time. And what are the atypical features? Atypical feature mean increased weight, appetite, and sleep. These are atypical feature sometimes present with depression. These are atypical. So after you make the diagnose according to the patient history, no, you we have to treat the patient. And in psychiatry, the first line is always cognitive behavior therapy, CBT. We will go for behavioral therapy or psychosocial family therapy or different types of therapy. But CBT is most preferred one. So CBT will be first line. If CBT is ineffective, then we will go for antidepressant medication. Antidepressant medication. In antidepressant medication, we have SSRI, selective serotonin reuptake inhibitor, or we have SNRI, selective norepinephrine reuptake inhibitor. We have as well as TCA. These are the drug we have for as an antidepressant, or we will go for atypical antidepressant, including mirtazapine. Mirtazapine. So these are the drug we have to add according to the patient situation. So in antidepressant, always first line is SSRI. First line, if we choose first line antidepressant, SSRI always come first. Then if SSRI is the ineffective, because SSRI have many major side effects like uh, GIT side effect or sexual dysfunction. And if patient complain their sexual dysfunction, so we have to change the drug into another class. As well as we will go for the same class, but most of the time this is ineffective, so we will move for another class like SNRI. So second, we will choose SNRI. Third, we will go for mirtazapine. Fourth, we will go for tricyclic antidepressant. Why tricyclic antidepressant we choose less? Because in elderly patients, due to the anticholinergic effect, we will choose less in elderly patient. So like this way, you have to add the medication in patient. We will discuss in drugs in detail along with name. So first of all, overview, you have to treat and you have to approach like this way if the patient present with uh, a depression. Always first cognitive behavior therapy. If cognitive behavior therapy is ineffective, then you will go for antidepressant medication. The antidepressant. If antidepressant is ineffective, then the last ray of hope is ECT, electroconvulsive therapy. These are subclasses of antidepressant, different classes of drugs. So in ACT is the last ray of hope. Doctor, does the things make sense so far? Any question, anybody, please? Doctors, please hurry up. So far, is everything is okay? Any questions? Okay. So the treatment must be secure the safety of the patient, and given suicide is a high risk. Pharmacotherapy, including antidepressant medication, including SSRI, tricyclic antidepressant, or monoamine oxidase inhibitor. And then the last will be ECT. But before going to this, the sequence which I tell you, you have to memorize this. Okay, doctor, move to next. There is some important management guideline. Mild depression, we will always go with psychological therapy, cognitive behavior therapy, psychological therapy. In case of moderate depression, we will always go with CBT along with antidepressant. If CBT is ineffective, psychological therapy ineffective, then we will add antidepressant. For severe depression, we will add antidepressant and consider addition of psychotherapy to maintain the remission, and consider psychiatric review. And if this is ineffective, then we will add ECT. CBT always first. Moderate depression, we will add antidepressant along with CBT is already continue. Then in case of severe depression, we will add antidepressant as first line drug along with CBT to maintain remission. If this is ineffective, then we will go for ECT. Easy thing, doctor. Don't worry. Move to next. Then we will add also as a combination in moderate therapy and as well as in severe, we will go for combination of therapy. Combination of antidepressant along with psychotherapy can be considered if there is an inadequate response to either therapy alone. Combination medication with psychological therapy is ineffective, and alone moderate or severe depression. Combining medication with psychological therapy is more effective as compared to alone. So we have to go with combination along with antidepressant and psychological therapy. Then ECT is last ray of hope, relative safe and effective therapy, but there have some like memory problem, retrograde or interrogate amnesia. This is another thing. So in electroconvulsive therapy, effective therapy for severe or resistant depression. Important, resistant depression. So in this case, we will go with ECT. And there's some risk of transient short-term cognitive impairment, long-term memory impairment. There is some risk present, short-term cognitive impairment and long-term memory problem. So this is a drawback of ECT and therapy reserved for severe depression when pharmacotherapy has failed and it is administered under the supervision of psychiatrist, and we will go for ECT after admission. And this ECT delivered by a trained psychiatrist, supervision of psychiatrist. So in hospital admission, we will go for ECT with supervision of psychiatrist, trained psychiatrist. And possible indication of ECT like psychotic depression, hallucination, and delusion. As we discussed, this is worse prognosis if these are present. Then melanic depression, unresponsive to antidepressant, severe postnatal depression and psychosis, substantial suicidal risk, ineffective antidepressant medication, and previous response to ECT. After trying the medication, we will, if ineffective so far, so we will go for ECT and as well as psychomotor depression, refuse to eat, drink, depressive stupor, and severe personal neglect. So these are the indication after simple indication like after the failure of SSRI, CBT, and resistance depression, the lost ray of hope, we will move for ECT. Not indication asking exam, but for your information. Dr. Simon repeats symptom of mild moderate to depression. In mild depression, there is a no life, daily routine life effective, and patient in as usual state, but sometimes the symptom. But in case of moderate depression, the social life is not too disturbed. For example, the patient is going to hospital in job as well as in social activity, eat normally, but sometimes sleep problem, a few uh, depressive symptom, but social life is not effective. In severe depression, the social life is effective. The patient have planned suicide intent plan, and anhedonia, loss of interest, fatigue all the time, and unable to sleep. So these are featured in severe depression. Severe depression mean the one word you have to memorize. Like if the patient have plan of suicide, this will be fall in category of severe depression, and the rest of the symptom also present. Anhedonia like this. Does it make sense, Dr. Simon? Okay. Okay, move to next. Doctor, there is SSI drugs classification. In SSRI classification, we have fluoxetine, citalopram, escitalopram, sertraline, paroxetine, and fluoxamine. These are the drugs of SSRI, and their side effect is already mentioned. Most common side effect, nausea, and least common side effect are written there. So fluoxetine, this is the first line medication we will choose always in SSRI group, and then we will choose sertraline as well, sertraline, then citalopram. We will choose like this. So if overall you can go through this side effect like the GIT upset most commonly in most common side effect as well as in least you can go through it's your own time, but the important side effect which I discussed with you, the important side effect is like there is GIT disturbance and sexual dysfunction, decreased libido in these patients, those who are using SSRI. So the important one is GI distress, GI distress, and as well as sexual dysfunction. This is the major side effect. And these recalls will in the question, like for example, a patient of for example 35 or 25-year male is already on sertraline for 3 months, no present with in with the feature of sexual dysfunction, and he's got newly married. So what you will do at this time? So they will give you option like change to another SSRI or change to another class of antidepressant or decrease dose or might be adds sildenafil. What you will do? So in this case, where the patient present like this with the dysfunction of with sexual dysfunction, you will always in antidepressant we have rule like you at the time you didn't go far to abruptly stop the drug. For example, patient in your clinic and say about the side effect of SSRI. The side effect is sexual dysfunction. Then you have to firstly taper off the drug. Firstly, you have to taper off. For example, you started the patient on 100 mg, and with the passage of time, you have to taper off 100 to 50 mg, 50 to 25, and then you stop the drug. Like this, uh, you have to treat the patient. For example, any SSRI patient 100 mg, you will go for 50, then once time 25 mg, then 12.5, and ultimately 0. Then you have to give the 3 to 4 day washout period. 3 to 4 day washout period in which there is a no any drug be taken by patient. Washout period after 3 to 4 day, then you will go for another class of drug like SNRI, like mirtazapine. So it depends upon at the time and the comorbs of the patient. So the changing of, for example, the patient is already on fluoxetine, and you will think I will change into citalopram. These things will not work because all SSRI have almost the same side effect as same side effect for sexual dysfunction. So you have to change the class of drug. Another antidepressant like SNRI, you will go for SNRI. So in option, they will give you the in option as well. Like you either you will go for the same class or you will go for another class. These are all the things will be in option. But most of the SSRI have a sexual dysfunction, so you will go for another class of SNRI, antidepressant class. Doctor, does the thing make sense? Are you guys with me so far or feeling overwhelmed? Mhm. In Australia, sertraline 100 mg came. Next, you will add SNRI or mirtazapine. Anyone you can choose. SNRI mean to say venlafaxine or duloxetine, or you can go for mirtazapine stepwise accordingly. Because in SSRI drugs, most of the drugs have the same side effect like GAD upset, sexual dysfunction, and other serotonergic syndrome. These are almost same. So you will go for another class of drug. But before going to another, you have to taper off the drug. 100 mg, for example, patient on 100 mg sertraline, you will go for 50 mg, then 25, then 12.5, then give 3 to 4 day washout period. It means washout period, no any drug in these 3 to 4 days, and then you will start new antidepressant drug, SNRI or metolazone or any TCA you will choose. Better to choose a second line SNRI. If not in option, then you will go for metolazone. So these are the side effects you can go through. It's your own time as well. Sertraline, important. Citalopram, fluoxetine is most commonly used. Fluoxamine and paroxetine also used as well in children depression. There is also SSRI side effect, common greater than 4, insomnia, sedation, appetite change, nausea, and important one is sexual dysfunction and sedation. Less common and rare side effect, this one. So this is doable. So move to next side effect of venlafaxine. Second line after SSRI is venlafaxine, as we discussed. And the venlafaxine, this side effect, nausea, headache, insomnia, side effect, important one, and also weight loss. Those patients who want to who are obese and want to weight loss, you will add SNRI. This is the benefit for these patients to uh, 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 remit remission of his symptom as well as along with weight loss. So this is a good medication option for this population: insomnia, doziness, and loss of appetite. Loss of appetite. So ultimately weight will be lost. And then also have some ejaculatory disorder and sweating. So important ones: weight loss, loss of appetite, insomnia, and ejaculatory. These you must know. And then a serious side effect of Effexor. Effexor, there is brand name which drugs use in Australia. Venlafaxine is their drug brand. Increasing blood pressure, seizure, increased risk of suicidal thinking behavior, suicidality in children, adolescents, and depression and other psychiatric disorders. So this is the side effect of SNRI. Then mirtazapine. In mirtazapine, also have side effect. Commonly reported side effect is sweat, sedation, constipation, drowsiness, increased serum cholesterol, weight gain, fatigue, insomnia, weight, increased appetite, xerostomia, and it means there is a metabolic problem in mirtazapine. And this is a new antidepressant medication. So after SSRI and SNRI, we will choose mirtazapine. And if this is ineffective, then we will go for TCA. This is the summary, like a drug name written taken by first aid: fluoxetine, fluoxamine, fluoxetine, sertraline, citalopram. This is all drugs over here. And adverse effect is sexual dysfunction, GIT disturbance, serotonin syndrome. SNRI, we have venlafaxine is important. You have to memorize this. Fluoxetine is important as well. And rest of just read. So their adverse effect is sexual dysfunction and nausea and other problem. TCA we will not prefer in old patient. Amitriptyline drug like nortriptyline, because these drugs cause uh, anti-energic effect, anticholinergic effect. So we will avoid this sedation along with postnatal hypotension, atropine-like anticholinergic adverse effect, including the tachycardia, urinary retention, dry mouth, and DCA. These are the side effects. And also goes in patient goes in convulsion, coma, cardiotoxicity. Due to this side effect, we didn't prefer this medication for treatment of depression. Okay, doctors, move to next the things we are discussed. So you people have to answer this question as well, because we all the things discussed. So a 72-year-old man come to office due to the worsening depression and insomnia since his wife died 7 months ago. The patient experienced lethargy, episode of tearfulness. He has little interest in socializing with his married friend anymore. He has attended 3 sessions of sportive psychotherapy and expresses appreciation for the referral because he liked the therapist. However, the patient continued to feel depressed and no experiences severe insomnia, and he has difficulty falling and studying asleep, frequently lying awake at night thinking about his wife. He feel very guilt about her death and believed that he should have done more for her during her final month. The patient experienced a moments of severe depression last week in which they briefly thought of suicide because of there is nothing left for me in this world. However, he assisted adamantly that he would never act as these thought. Physical examination show a 4.5 kg weight loss since his wife death. Which of the following is the most appropriate next step in this management? So option A, increase the frequency of the psychotherapy session twice a week. Option B, prescribe amitriptyline and continue psychotherapy. Option C, prescribe mirtazapine and continue psychotherapy. Option D, prescribe zolpidem for insomnia and continue psychotherapy. Option E, provide reassurance and continue psychotherapy. Option F, recommended ECT. Doctors try to think and try to answer. So, see here, the depressive criteria is fulfilled. As the insomnia is present, little interest present, lethargy present, episode of tearfulness. Your diagnosis for depression is fulfilled. No, the patient is depressive state, and already he joined the psychotherapy session, but there is a ineffective RS. So, no, the patient is further feeling depressed. First lethargic, two episode of tearfulness, then anhedonia, interest, a little interest, as well as insomnia, and not enjoying his life. So, and patient feeling depressed, as well as attended the psychotherapy session, but ineffective, and awake all at the night thinking about his wife and feeling guilt. So, feeling guilt, it means the depression criteria is fulfilled, and believes that he has done more for her during his final month. So the CBT is ineffective, then what you add in next step? Doctors try to think. The CBT is ineffective. So if you go for rule out criteria, for example, if you don't know the answer, and what you do, and the important things, the most appropriate next step, not in definitive step, next step. So according to this situation, you have to manage the patient. As I explained, we will never go for ECT, never go directly. ECT is the last ray of hope. So far the patient only tried the psychotherapy. So this is rule out. Recommended ECT, provide reassurance and continue psychotherapy is ineffective because the psychotherapy session is already patient taken. So rule out this one. Psychotherapy continue, no, this is wrong answer. Reassurance because the patient is no in very depressive state, and also have thought of suicide. So this is a patient in high risk category. So you have to treat. Prescribe zolpidem, no, no for insomnia, and continue psychotherapy, no, never. Zolpidem is very less rare use in Australia, so don't go with this. And then increase the frequency of psychotherapy session twice weekly, no. This is already ineffective. So amitriptyline, as we discussed, and psychotherapy, you have two options. So in these two options, you are confused, right? So amitriptyline, as we discussed, this is the class of tricyclic antidepressant, and this is uh, as this drug have as a major side effect like anticholinergic side effect. So it is less commonly used. So rule out this. Then mirtazapine and the continuous psychotherapy. This will be the choice for this patient. So like this way you have to think, because there is no any option of SSRI over there. So if the SSRI option will be there, so you will go for SSRI first line, like citalopram, fluoxetine, like this. But there is no option, so we will go for mirtazapine and psychotherapy. Or there is no anti-drug of SNRI. So directly, as I discussed, SSRI always first. Second, you will think about SNRI. Third, you will go for neural antidepressant like mirtazapine. mirtazapine. Fourth, you will go for TCA, tricyclic antidepressant, amitriptyline like this. So first of all, you must know the name and classification of drug, what including in SRI, SNRI, TCA. So first, you should know. So hope so you will understand this. Like this way, you have to approach in exam question as well. So these drugs I already mentioned over there, so you can go through it your own time as well. Fluoxetine, sertraline, citalopram, these are SSRI, and SNRI, venlafaxine, duloxetine, and amitriptyline, non-amitriptyline. These are in TCA and mirtazapine. So the correct option is C. Prescribe mirtazapine and continue psychotherapy. Okay, good. Dr. Saima, Dr. Lare, Dr. Slim with C. Okay, Dr. Good. It means you are understanding the things which we are discussing. And next topic, doctors continue treatment. So it is recommended that the continue should be minimum 12 weeks for initial episode. If patient present with initial episode, you will continue this treatment for 12 months, because if you patient withdraw before 12 months, there is a most probable chance the patient will get a remission of the depressive symptoms. So minimum for 12 weeks and 2 to 3 years for subsequent episodes for relapse. But in few guidelines say for 3 to 5 years, but few say 2 to 3 years. And risk factor for relapsing, including the residual depressive symptom 2 or more, episode 3. So this is not important. And one more important things is there. For example, if patient came to you after the using of drug 2 to 3 weeks and saying that there is not effective for me, then what you have to do for this patient? Doctor, answer. For example, patient use antidepressant just 2 to 3 weeks, but this is ineffective, and patient again came to your clinic. Then what you should do at this moment? So, doctor, in this stage, you will counsel the patient that at least, yes, counseling, yes, at least SSRI should need to be effective at least for 4 to 6 weeks. So, counsel the patient, and say to patient, this drug will be effective after using a 4 to 6 weeks. 4 to 6 week use, then it will produce effect. So this is important. SSRI will take time to produce his effectiveness. Move to next, doctor. Depression in children and adolescent. They things same as in adult, but the children sadness is common in children. Depression also is not common, and the symptom like feeling of helplessness, worthlessness, and despair. Major depression in children and adolescent may be diagnosed using the same criteria as for adult, and the patient mainly with namely loss of interest, not going to school, and as well as in usual activities, loss interest, presence of sad or irritable mood, persistent for 2 weeks, and ill children irritability may be more prominent than sadness. Irritability, like the child is irritated all the time, crying like this, and aggressive sometimes more prominent than sadness. Sadness mostly most common in adults. In adults. So the other depressive symptom, including the somatic symptom present, example is difficult in getting to sleep, not enjoying the meal, poor concentration, and poor self-esteem, poor motor skill. These are the feature of depression in children. And depressed adolescents are difficult to challenge for general practitioner. Effective engagement are established to report in youth-friendly environment is critical. So, uh, for depression in children, you have to treat, and for drug of choice to treat depression in children is fluvoxamine, fluvoxamine, or you can go with fluoxetine. These are the group of SSR. So if depression in children, the drug of choice is fluoxamine or fluoxetine.